A very good morning to all of you. We once again welcome you to this webinar series co-organized by the GMOA and the Society for Health Research and Innovation in our series of educating our primary care practitioners on timely topics. Let me get on to some housekeeping rules. As usual, this webinar link will be available from 9 a.m. till 9:50 a.m. for all of you to log in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of this webinar to obtain the certificate for CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. These strict rules we have enforced is to maintain the standards of our CPD program conducted by Shri and GMOA. We once again thank you for logging in for today's session, and we would like to highlight that today's topic is a very timely and essential topic under the heading of hypertension, practice essentials for primary healthcare practitioners. Since there's also technical difficulties with the power cuts in the island, we will post a phone number for all of you to text your details if you get logged out during the session so that you can get logged back in during this webinar. We have also opened our Q&A session. So any questions or queries you have during this webinar, you can type in our text bar so that we can discuss at the end of this webinar. We also kindly ask you all to mute your microphones and also to switch off your video so that there will be no interruptions during this webinar. Without further ado, I would like to invite Dr. Himal today as well to give the introduction to our very prestigious and very young consultant who is with us today to present our webinar. Over to you.
Thank you, Dr. Rumali. Good morning, everyone. It's my great pleasure to introduce today's our resource person, who is Dr. Chamara Dalugama, a consultant physician at Professional Medical Unit and senior lecturer in Department of Medicine in University of Peradeniya. He's a product of University of Peradeniya, and throughout his career, he has gained a lot of rewards and awards. And he's recently board certified very young consultant, and he has over 10 publications regarding medicine topics as well as rewards. So it's my actually great pleasure to introduce Dr. Chamara Dalugama to this audience. Today, he is going to speak us regarding primary hypertension in primary health care. I would like to thank Dr. Dalugama to joining us all the way from Peradeniya online. So without further ado, I will invite Dr. Dalugama to give his talk. Dalugama.
Okay, thank you, Himal. Let me share the screen first. Very good morning to you all. And first of all, I must thank the GMOA and the Sri for arranging this sort of CME activity for doctors. And also, I would like to thank the College of Internal Medicine for giving me this opportunity to talk to you here. So today, as in the introduction, it was mentioned, a very timely and important topic that I'm going to discuss. That is about hypertension, and I will be mainly focusing about practice essentials for primary healthcare practitioners. So as I mentioned, this is timely and important because of two main reasons. The one reason is, when you go along the lecture, you will know that hypertension is the #1 killer among non-communicable diseases. And the second thing is, this is largely asymptomatic. So the primary healthcare practitioners will pick up hypertension, and they will usually make the first ever diagnosis of hypertension. So this becomes really important. And so for the primary healthcare practitioners to have a sound knowledge about the management of hypertension. Right. So the outline of today's talk will be, I will be briefly discussing about the global and Sri Lankan situation and about the burden of hypertension and the presentation of hypertension, and I'll be more focusing about the diagnosis, workup, and when to start treatment and what to start for treatment. Right, so talking about the global burden, so this is a world map depicting the prevalence percentages of hypertension. So if you see this map, you will see that most of the Asian, African, and the South American countries carry a very high prevalence of hypertension. And of course, the global prevalence goes up to 1/3 of the world population. And if you compare this map with a map maybe 20, 30 years back, you will clearly notice that this high prevalence is shifting from high income countries to low income countries like ours. So we are going to be having this hypertension, ever increasing hypertension burden for so many years to come. And talking about the Sri Lankan situation, there's an interesting study done by Professor Katulanda and team, where they have shown that 1/3 of the Sri Lankan adult population is hypertensive. So what is the burden of hypertension, right? So this chart will clearly show you, this is basically a chart depicting the deaths attributable for individual risks, right? So there are a lot of non-communicable diseases listed here. So you will see clearly that hypertension is the number one. So you have smoking, you have obesity and overweight, diabetes, dyslipidemia, everything, but they all rank below hypertension. So in summary, hypertension is the leading cause of mortality and morbidity worldwide. So talking about the burden of hypertension, basically, it has a lot of adverse cardiovascular outcomes. It can be a myocardial infarction, it can be a stroke, it can be peripheral vascular disease. And it has a lot of adverse renal outcomes. There are so many patients who are sort of gone into end-stage renal failure, needing dialysis because of hypertension. And hypertension has a bad effect on the cognition. There's a lot of patients with cognitive decline and dementia where the risk factor is hypertension. And it's a threat to vision. There's a lot of people who are blind because of hypertension. And it is the number one cause for all-cause mortality as well. So this will clearly show you how significant the burden of hypertension is. So when we talk about the presentation, this is the problem. Hypertension is largely asymptomatic, right? So unless you pick up hypertension by a screening, most of the patients will not know that they have hypertension for so many years. So the initial presentation of hypertension may be with a complication such as maybe a stroke, maybe a myocardial infarction, or maybe a renal impairment, or most of the time it may be an incidental finding of a high blood pressure when the patient comes to a general practitioner or a primary healthcare provider with some other complaints, maybe with a fever, maybe with a diarrhea. You just check the blood pressure, you find the patient is hypertensive. So that is why, very correctly, the hypertension is given the name a killer in disguise. So it's a silent killer, right? So that is why this becomes very important when it comes to the primary healthcare point of view. So most of the patients with hypertension, they present to primary healthcare centers, and most of the time, the first ever diagnosis of hypertension is made by the primary healthcare providers. Right. So other than this asymptomatic presentation, there are some other presentation as well, where in secondary hypertension, patient can have different clinical presentations related to the underlying cause. Say, for instance, if it's a pheochromocytoma causing hypertension, patient might have episodic sweating, headache, and palpitations. And you might find a patient with poor glycemic control, easy bruising, proximal myopathy. You might suspect could this be Cushing's. Patient might come with severe muscle weakness or even paralysis due to hypokalemia and can have hypertension in cons. And sometimes patient can have intermittent claudication in coarctation of aorta. So there can be other presentations, but if you take the vast majority, the presentation is most of the time asymptomatic, or they can come with the complication related to hypertension. Right. So now we will define what is hypertension. Unfortunately, although this is very common, there is no universally agreed definition for hypertension. So there are so many colleges, so many societies have given different definitions, different cutoff values for blood pressure, right? But this is understandable because, hypertension is a continuous variable, right? So if any physiological variable will have a normal distribution in the society, right? So you will have patients with low normal blood pressure, high normal blood pressure, which are like distributed like a normal distribution curve. So in this normal distribution, it is very difficult to define one exact value. Okay, above this value, you will be hypertensive. So the current practice is that the blood pressure level at which the interventions improve outcome and benefits outweigh the risks is defined as hypertension, right? So they have arbitrarily given a value, okay, after this value, if your blood pressure is more than this, and if you treat, it improves the outcome. The benefits outweigh the risks. So we'll define this value as hypertension. So the European Society of Cardiology and the International Hypertension Society has agreed on this definition, where the systolic blood pressure more than 140 in the office or in the clinic and a diastolic blood pressure more than 90 in repeated measurements can be defined as hypertension. So we will, from this point onwards, we will stick to this definition of hypertension. Right. So to define hypertension, you should measure the blood pressure. And this blood pressure measuring is something that what we have been doing from our early medical student days. It's a very simple thing that we have been doing almost every day in so many patients. But I will take 1 to 2 minutes to discuss the correct technique of blood pressure measurement, because that is very important when it comes to diagnosis. The most important thing is using a validated machine, right? Sometimes in boards we see some blood pressure meters are like 10-15 years old and they have never been recalibrated. So they may be reading a falsely high or falsely low value. So it's very important that you have a validated blood pressure machine. The second thing is always make sure when you check the blood pressure of the patient that in the 30 minutes before your measurement, the patient has not smoked, not done any strenuous exercise, not had any caffeinated beverages, maybe coffee, or no alcohol, right? Because these things are going to significantly affect your blood pressure value. And then get your patient to sit at least for 5 minutes and relax before the blood pressure measurement is taken. I know this is somewhat difficult when it comes to busy OPD, but there are things that we can do to sort of optimize our blood pressure measurement. And then you have to select the appropriate cuff size, because sometimes the cuff size can overestimate or underestimate the blood pressure. So you should take the proper cuff size, which is covering 2/3 of your arm, and always make sure you wrap it against the skin, but not against the clothing. This is again something that commonly we do in a busy clinic. We just apply the blood pressure cuff over the clothing. And then when you're measuring the blood pressure, get the patient to relax, don't let him talk, and get him to keep the arm comfortably, the cuffed arm comfortably on a flat surface at the heart level. And always get the patient to sit upright, back supported, and feet on the floor and legs uncrossed, right? So this is the correct technique of measuring the blood pressure. I know there are so many things, there are so many criteria to be fulfilled to have a correct blood pressure measurement, right? So now you have measured the blood pressure, right? So I will briefly talk about different settings of blood pressure monitoring. So the commonest setting when it comes to primary healthcare is the office blood pressure monitoring, where the patient comes to you, maybe a clinic, maybe an OPD, sometimes it can be a ward, where you take the blood pressure monitoring. So to confirm the diagnosis of hypertension, always in the clinic, we will need repeated measurements, right? And then the other thing is this blood pressure in the office can be done in 2 ways. One is it can be attended, where a doctor or a nurse check the blood pressure, or it can be unattended. In other countries, they have a lot of automated office blood pressure readings, where there's no doctor or nurse nearby, the cuff is there, patient sort of, the instructions are given, so the patient applies the cuff and get the blood pressure reading done. So this is very effective when it comes to the white coat defect, which we will discuss shortly, to eliminate the white coat defect. And the current era where we talk about COVID and distancing, this will be ideal to have automated office blood pressure reading. And then we can have out of office blood pressure reading as well. So where one is the ambulatory blood pressure and the other one is home blood pressure. And the ambulatory blood pressure is very important because it measures your day and night blood pressure, and you have been doing your normal activities. So it is more physiological and you will have multiple readings, and it is going to be more accurate because it sort of eliminates a lot of confounders, a lot of biases. Sometimes the patient might be anxious when he sees a healthcare practitioner, which we commonly label as white coat defect, and might have a falsely high blood pressure reading, right? So the ambulatory blood pressure would be ideal when it comes to diagnosis of hypertension, but the problem is this is not widely available in primary healthcare. Even in government sector, we have limited number of ambulatory blood pressure monitors, so it difficult. And if you want to get it done through private sector, it is costly. And the other more practical option would be to go for home blood pressure monitoring, where we encourage the patient to sort of get his blood pressure monitored and recorded. But here again, there are practical issues where the patient need to have a blood pressure monitor at home and he should follow the proper technique, etc. Right. Fine. Then, okay, now you have a patient. So I will take you to a clinic setting where you have a patient and what to be done in the first visit. Right. So the patient is there. Always make sure in the first visit that you measure the blood pressure in both arms. And if there is a difference in the arm, take the arm with a higher reading. Right. So if the difference is very significant, say for instance, maybe 20, 30 mercury millimeters, that needs further investigations. But if there is a subtle difference, always take the arm with the higher reading. And if your blood pressure measurement is more than 135 and or the diastole is 85 or more, you need to take 2 more readings at least 30 seconds apart. And we can discard the first reading and we can take the average of the second and third reading, right? So you patient comes, you measure the blood pressure in the both arms, and if they are equal, that's fine. If there is a subtle difference, you take the arm with the higher reading, and if the blood pressure reading is more than 135 or 85, take 2 more readings, discard the first one, and take the average of the second or third reading, right? Okay, so now we have done that blood pressure measurement according to the technique that we have discussed, and the average comes more than 180 and 110. So this is a fairly high blood pressure. The next thing you need to do is see the patient and see whether the patient is in severe pain or distress, or whether there are any physiological cause for his high blood pressure, right? So this can be common. You might find an old person coming and reading the blood pressure of 180 by 110, but he is in distress, he is agitated, and you find he has a large percussible bladder. So probably he is in severe distress because of urine retention. So in that case, there is a physiological cause accounting for this blood pressure. So probably you will treat that and you recheck the blood pressure. But there's no physiological cause. Patient is there and you read the blood pressure, it is 180 by 110. The next most important thing is blood pressure is too high. You have to see whether there is any hypertensive emergency. So by definition, hypertensive emergency is that blood pressure is too high and it is causing acute target organ damage, right? So this target organ can be your heart, can be your brain, it can be your kidney or liver. So if the patient is having angina with that high blood pressure, or if the patient has acute heart failure, he is short of breath, he has bibasal fine crackers, or if the patient has any neurological deficit, right, he may be having some weakness, some severe headache, or if the patient has any evidence of acute kidney injury, this becomes a hypertensive emergency where in primary healthcare, it's not the setting to treat this sort of a thing. So patient will need immediate admission and a specialist referral, right? But the blood pressure is pretty high, but in your assessment, the patient does not have hypertensive evidence of hypertensive emergency clinically. No chest pain, no heart failure, no stroke. Patient looks clinically perfectly fine. Then you can consider treating the patient at the primary healthcare setting, but we have to look for asymptomatic target organ damage, which we will discuss briefly. Right. Okay, the second scenario would be, okay, you check the blood pressure. The blood pressure comes as 130 to 180, 179. And the diastole is 85 to 109. Okay, so blood pressure is high, but it's not too high. And in this sort of a scenario, it's very important that you confirm your diagnosis in 2 to 3 measurements on 2 to 3 occasions, right? So if you have the facility to offer only the office blood pressure, what we can do is, okay, you tell the patient, okay, look here, your blood pressure is high, say it's 150, 100, okay, your blood pressure is high, but you offer him at least come another time for a repeat blood pressure measurement in a very nearby day, right? That helps you to sort of confirm the diagnosis of hypertension in repeated measurements. But the ideal would be if you find a patient with a blood pressure, say 150, 100, offer them the ambulatory blood pressure monitoring. So the patient wears the blood pressure cuff 24 hours, he does all his normal activities, and then you get the reading, okay, then you can make a diagnosis whether he's hypertensive or not. So this would be the gold standard to get out of office blood pressure measurement. But in practical settings, if it is difficult, get the patient to come back maybe later in the same day or maybe in the following day, get a repeated measurement and see whether the hypertension diagnosis can be confirmed or not. Right. So this is how we confirm the diagnosis of hypertension. So this is the criteria for hypertension based on office, ambulatory or home blood pressure measurement. And these are, ideally speaking, in repeated measurements. So your clinic blood pressure is more than 140/90 in repeated measurements. Okay, you can label the patient. Okay, he's hypertensive. But when it comes to ambulatory blood pressure monitoring, the values are slightly lower. So the 24 average blood pressure that you get in the ABPM, if it is more than 130/80, you can label the patient is hypertensive. And the daytime average is 135/85, and nighttime, interestingly, it's 120/70. So if you take the ambulatory blood pressure monitoring and the nighttime average is 125/75, still you make a diagnosis of hypertension. And if the patient comes with repeated home blood pressure monitoring, and if the blood pressure readings are always more than 135/85, again, you can make a diagnosis of high blood pressure. Right. So this is again an interesting slide where we discuss about blood pressure phenotypes, right? So this may not be that relevant to today's topic, but it will be interesting because this side shows, the left side shows the office blood pressure readings, right? So in the office, you take a blood pressure and it's 149. And the x-axis shows the ambulatory blood pressure monitoring, right? So your office blood pressure is say 130/80, and your ambulatory blood pressure is also 130/80. So you can label the patient, okay, he does not have blood pressure, he's normotensive. And in the other spectrum, your office blood pressure is say 150/100, right? So it's more than 140/90, and you do the ambulatory blood pressure monitoring, that again comes as 150/100. So this is clearly a hypertensive patient. But in between these two categories, there are two other categories. One category is what we call white coat hypertension. Actually speaking, among the hypertensives we see, 20 to 30% can have this white coat hypertension. What it means is, whenever you check this patient's blood pressure in the office, in the clinic, that is high, say it's 150/100. But when you offer him the ambulatory blood pressure monitoring or home blood pressure monitoring, that is normal. It doesn't fulfill the criteria for hypertension. Say it can come as say 120/70. So this group is called white coat hypertension. So they have the white coat effect. Clinic, the blood pressure is high, but in physiological settings, the blood pressure is normal. But the worst category you can see is this, the masked hypertension. That is, whenever the patient comes to the clinic, the blood pressure is normal. But when you offer them the ambulatory blood pressure monitoring or home blood pressure monitoring, they are hypertensive. So there's no clear reason why this happens, but 10% of hypertensives can have masked hypertension. And unfortunately, this group will not be diagnosed unless we do ambulatory blood pressure monitoring. Because whenever they come to the clinic, they will read a normal blood pressure, and we hardly offer them ambulatory blood pressure monitoring. So the instances where you should suspect this masked hypertension, I will give you a few examples. You have a patient, normal blood pressure, but when you look at the ECG, that shows severe left ventricular hypertrophy. Or you happen to see an echocardiogram of the patient, it says, okay, there's severe concentric LVH. Or else the patient might come with some unexplained renal impairment. Or patient might have some form of proteinuria. So you can't explain, he doesn't have diabetes, he doesn't have anything. Then you have to think, could this be masked hypertension, where we don't pick up in the office, but he is hypertensive throughout the day, right? So those are the 4 blood pressure phenotypes. So the normotension is good, white coat hypertension is okay, but hypertension you need to treat, and masked hypertension is the real killer, which is in disguise, which we will not be able to diagnose in routine setting, right? And this is something that all we know, the blood pressure classification. So grade 1 is 140 to 59, and grade 2 and grade 3 is more than 180. And you have a normal blood pressure, and we have a high normal blood pressure range as well, right? Okay, so I will not read out this chart, but I mean, obviously you will know the grades and the types of the hypertension classification, right? Next, I will discuss what to do in the first visit. So now you have seen the patient, you have done the blood pressure measurement correctly, and you have made the diagnosis of hypertension. And then in your initial evaluation in the clinic or in your practice, first thing is to see, try to exclude and identify the secondary causes of hypertension, which we will discuss. And the second thing is you have to determine, okay, how badly the hypertension has affected this man's organs, right? As you know, hypertension affects all the organs. So how badly it has affected the organs of this particular person. And third thing is to say, okay, he has hypertension, and usually if you have hypertension, you can have other cardiovascular risks as well, because we always treat a person, not a disease. So you diagnose hypertension, always try to assess the total cardiovascular risk of the individual, right? Okay, so this is a slide about the secondary hypertension, secondary causes for hypertension. Actually, I will not discuss in detail because that is not the scope of the lecture today. But particularly if you see a younger patient, a difficult to control hypertension and a hypertension, which is poorly responding to treatment, you have to think about secondary causes. There are so many, right? There can be endocrine causes like acromegaly, thyrotoxicosis, and sometimes primary hyperaldosteronism, etc. And sometimes there can be vascular causes, maybe coarctation of aorta, maybe renal artery stenosis, and sometimes obstructive sleep apnea, right? The only clue that you will get is the wife might complain, okay, he snores throughout the night, he is snoring. So that may be a hint, okay, could this be the reason why he is hypertensive? And then drugs. There are many drugs that can cause drug-induced hypertension or induce hypertension. So commonly, the steroids that we use, the NSAIDs, oral contraceptive pills, those are common culprits. Right? So always, whenever you assess a patient with hypertension, think, could there be a secondary element for this hypertension so that we can treat it? And then you need to determine the target organ damage, right? So the target organ can be your eye, can be the heart, can be the peripheral arteries, can be the kidney, or can be the brain. So you have to see whether the patient has any evidence of target organ damage. This can be picked up by clinically, or sometimes if the patient is asymptomatic, there can be other investigations or examination things that you can do to pick up the target organ damage. Right, and then it is very important to assess the total cardiovascular risk of the individual, right? So always take your time to see whether the patient is smoking, whether the patient is diabetic or dyslipidemic. So if he has not been screened at the time of diagnosis of hypertension, offer him screening for diabetes, screening for dyslipidemia, and see whether he has established coronary artery disease, any cerebrovascular disease, proteinuria, CKD, and significant family history of premature coronary artery disease, right? So there are a lot of calculators as well that you can nicely sort of download into your smartphone, where you have to just enter whether the patient is a smoker, what's the sugar, what's the cholesterol level, and what's the family history, is he a male or a female, and then that will give you the percentage, the 10-year cardiovascular risk of that particular person, right? Okay, so it's important to assess the total cardiovascular risk of the individual, right? Now, so those were the aims of initial evaluation. Now we are going to sort of manage this patient, right? So in the first visit, you need to take a good history, right? So you make a diagnosis of hypertension, always ask about the symptoms suggestive of secondary causes, but we have already discussed, right? So it may be episodic headache and palpitation, maybe proximal muscle weakness, or it may be snoring at night, etc. And always ask for past history of ischemic heart disease, renal disease, and take a detailed drug history, right? Patient may be taking over-the-counter NSAIDs and steroids for a joint problem, and that may be the reason why the patient is hypertensive. And a history about smoking, ethanol, and a good family history of premature coronary artery disease. So do a basic assessment from the history. And then the next thing is the examination. So always in your hypertensive patient, I know all these things will not be feasible in a busy clinic setup, but at least few things, right? So get an idea about the patient's weight and height and the BMI, and see whether the patient is pale, whether he has ankle edema, and what's the pulse, whether there is any evidence of heart failure, any murmurs, and just have a feel of the tummy to see whether he has got palatable kidneys, right? So then that might tell you the diagnosis. And then look for features of endocrine diseases. You might see a patient with a moon face, with some purple stripe, easy bruising. You might think, could this be Cushing's? Sometimes you can see post facial features, large hands, could be acromegaly, right? So always do a brief examination, focused examination to look for these things. And then the basic investigations, right? So in the primary healthcare setting, I know there are not many investigations are available, but there are simple things that we can do to sort of help us to differentiate or to look for secondary causes and to assess the extent of target organ damage and to get an overall cardiovascular disease risk assessment, right? A simple thing would be a urine dip. Yeah, you will look for protein and red cells, and then you can do renal functions, serum creatinine and serum electrolytes, transaminases, and hemoglobin. And always take the opportunity to screen them for diabetes and dyslipidemia and a 12-lead DCG. So these are the simple investigations: a urine dip, a creatinine, a hemoglobin, electrolyte, ALT, and the lipids and the sugars, and a 12-lead ECG for the initial workup of a hypertensive patient. Right. And once you do this, so you have taken the history, you have examined the patient, and then you have done the basic investigations, you need to set targets in the treatment. So your target is, in all patients, you should control the blood pressure below 140/90. Right? And once this target is achieved, you can go for 130/80 if they are tolerating it without undue side effects. And your patient is sort of a younger patient. Here the cutoff is 80, but if less than 80, you can even go for systolic blood pressure 120 to 129 if the patient is tolerating. And always target to have a diastolic blood pressure less than 80 in all the patients. Right, so that is how we should set targets in treatment, right? Okay, and then we will discuss briefly about the treatment. So when it comes to treatment, we have two main arms. We have the non-pharmacological and the pharmacological. So the non-pharmacological is basically the lifestyle changes that I will briefly discuss, and that is for everyone. And the pharmacological treatment you can consider in selected categories. So this is a very interesting slide. This is adapted from the American College of Cardiology 2017 guideline. So they have shown that lifestyle changes alone have a significant effect on reducing the systolic blood pressure. DASH diet, which I will discuss shortly, is shown to reduce blood pressure by 11 mercury millimeters without any other interventions. And increase in exercise, 4 to 8 mercury millimeter reduction of systolic blood pressure. And losing weight, for each kilogram you lose, there will be 1 millimeter mercury reduction of your blood pressure. Right. So with regard to lifestyle changes, one interesting or one very important research proven dietary recommendation is what we call a DASH diet. The word DASH stands for dietary approaches to stop hypertension. It is rather a guideline for a healthier and a more balanced diet, right? So it is not something very difficult. It's just a matter that sort of you change the number of servings you take and the selection of food during the diet, right? So I will just briefly discuss this. So if you take all what you eat for 24 hours in a big plate, 1/3 of that should be grains. So in our setup, it may be rice, it can be, basically grains. And then 1/3, it should be fresh fruits and vegetables. So this is where we don't practice. We have a heap full of rice in our plate and we sort of serve ourselves with very small quantities of vegetables and hardly any fruits. But the DASH diet recommends equal amount. 1/3 of the diet should be fresh fruits and vegetables. And when it comes to vegetables, mainly green leafy vegetables because they have less calories in contrast to starchy vegetables. And the fruits, again, very important in DASH diet because it's a very good source of potassium. And potassium is known to reduce your blood pressure. And then when it comes to meat, it should be lean meat, the meat which is out where you have removed the fat and oil. And then you can add some nuts and seeds to your diet. And the dairy products should be low fat or non-fat. And the DASH diet says that you should take less than 1 teaspoon of oil or fat each day, right? That discourage taking oil intake. And also DASH diet talks about salt intake, right? So your salt intake should be reduced to less than 1 teaspoon a day. Right. In addition to DASH diet, the exercises, quitting smoking, and cut down on your alcohol, they all are very good, effective non-pharmacological measures. Right. So we will go to the main bulk of the topic. So that is the pharmacological treatment. So how do you treat hypertension pharmacologically? So the first question is, do you start drugs in everybody? The answer is no. Right. Although you make a diagnosis of hypertension, it's not everybody that needs treatment. So you need to start treatment. Obviously, if the blood pressure is more than 180, 110, the grade 3 hypertension, you need to start treatment. And in grade 2 hypertension as well, where the blood pressure is more than 160, 100, you need to start treatment. But if your blood pressure is in this category, where it is 140 to 159, diastole is 90 to 99, what you call grade 1 hypertension, look for few things, and if they are there, you start the treatment. But if they are not there, you can offer them lifestyle modifications. So what you should look for? Example, if you say you find a patient's blood pressure is 150 by 95, right? So that is grade 1 hypertension. See whether this patient has established cardiovascular disease, whether this patient has angina, whether the patient has had a stroke, a TIA, or peripheral vascular disease, or whether the patient has proteinuria or renal impairment, or whether the patient has any other target organ damage, or whether the patient is a diabetic. So this category will definitely need treatment. But if you find the patient's blood pressure is in this range, mild hypertension, grade 1 hypertension, but no cardiovascular disease, no albuminuria, no target organ damage, and no diabetes. So in this group, obviously, you can manage with lifestyle modifications alone, but this group needs close monitoring of their blood pressure to see whether the lifestyle modifications are effective and whether they go into grade 2 hypertension, where you need to start them on treatment. Right. And then there's this other interesting category where the blood pressure is sort of not diagnosed as hypertension, right? So blood pressure is 130 to 139 and diastole is 80 to 89. So what we call in classification, high normal blood pressure. But if this group has established coronary artery disease, right? The patient has had a myocardial infarction and he had a stent. So in this group, it's important to consider drug therapy, although they are not hypertensive, for secondary prevention. Right. Okay, so then we will talk what medications to start. So the initial treatment, you have 3 choices. You can go for ACE inhibitor or ARB, angiotensin receptor blocker. In examples, ACE inhibitor could be your captopril, enalapril, and your angiotensin receptor blocker may be something like losartan. The second choice would be you can go for a calcium channel blocker. Or the third choice is a thiazide diuretic, right? So you can select one of these categories to treat the patient as the initial treatment of hypertension. Although this was practiced many years back, now the beta blockers are no longer recommended as the first-line antihypertensive therapy, right? Although we see there are a lot of patients who have been started on atenolol as the first-line treatment, it should not be encouraged, right? So beta blockers are no longer recommended. So you can select one of these categories, either a ACE inhibitor or a calcium channel blocker or a thiazide diuretic, right? So we will take one by one. So you have mild hypertension, and there is a reason to treat, as we discussed. Either patient is diabetic, or patient is having some coronary artery disease, or something like that. So in grade 1 hypertension, of course, we can consider starting them on a single antihypertensive treatment, what we call a monotherapy. So a younger patient, an ACE inhibitor or an ARB would be preferred, and in an older person, a calcium channel blocker would be preferred. Right? Still, you have the choice that you can select any of these medications out of the three categories, but the preference is in younger age for ACE inhibitor or ARB, and in old age for a calcium channel blocker. But if your patient is a diabetic, irrespective of the age, always consider an ACE inhibitor or an ARB as the first line treatment. Right. And then when it comes to grade 2 hypertension, where the blood pressure is, initial blood pressure is more than 160/100. Right. So the current recommendation is to go for a combination therapy. So you can select two drugs from two different complementary classes at lower doses. Right. There was a practice where we used to start a ACE inhibitor or ARB and go to the maximum dose, and then not settling, we used to introduce another drug. But the current practice is from grade 2 hypertension onwards, start two drugs from two different classes at lower doses and then gradually up titrate. And now there are single pill combinations, right? So there are, sometimes in hospital sector, but commonly in private sector, there are combination pills, say for instance, losartan and HCT. So that will help to improve the compliance, and that will reduce the pill burden as well. Or else you can use separate tablets, right? So grade 2 onwards, it's a combination therapy of two drugs in two different classes. And then the choice of this initial antihypertensive, as I discussed, will depend on so many other factors. One is the presence of target organ damage. And then the second is presence of other comorbid conditions. And importantly, the patient's compliance and the cost and availability. So I will briefly discuss few conditions where you can have a sort of a preference over each medication. So if the patient is a diabetic, the ACE inhibitors and angiotensin receptor blockers are preferred over the others because they have other beneficial effects, particularly when it comes to diabetic kidney disease. The ARBs and ACE inhibitors have a beneficial effect. And then the patients with asymptomatic target organ damage, you might find LVH in the ECG or echo. Patient may be having proteinuria, or patient may be having early CKD. Again, ACE inhibitors and ARBs are preferred over other classes. And if the patient is a stroke, sometimes you can consider thiazides and calcium channel blockers over the other medications. And advanced CKD, you can consider calcium channel blockers. And ACE inhibitors and ARBs can be used. They are antiproteinuric, but in end-stage renal failure, you have to be a bit cautious because these people are hyperkalemic, and sometimes your losartan or enalapril might make the hyperkalemia worse. And then you can have coronary heart diseases where there is a compelling indication to go for a beta blocker, right? So usually beta blockers are not recommended as first line treatment, but if your patient is a patient who has angina and who has had a myocardial infarction, we can use a beta blocker as an anti-anginal and at the same time to have an effect on the blood pressure. And then, yes, in heart failure, you can use ACE inhibitors and ARBs. And in peripheral vascular diseases, you can use ACE inhibitors, ARBs. But if the patient is on a beta blocker, that need discontinuation because beta blockers might worsen the peripheral vascular disease, right? There are so many conditions, and you have three drugs to choose. And another fourth drug, that is the beta blocker, if there is a compelling indication. So depending on the patient's other conditions, you will have to sort of select over each medication what is best for the patient. So, okay, right. So, well, this is somewhat hypothetical, but what is the best pressure pill, right? So the most important thing is, if you think about, if you are sort of want to design the best pressure pill for a patient, the most important thing is that need to be well tolerated with minimal adverse effects. The reason is, as we discussed earlier, most of the hypertensive patients are asymptomatic. They just come for some other thing to your practice, and you make a diagnosis of hypertension. Until that time, they had been perfectly fine clinically. But once you start the antihypertensives, they will get a lot of other adverse effects, right? So if you start HCT, they might complain of erectile dysfunction. If you start nifedipine or amlodipine, they might complain after the medications, I have this leg swelling, or I have headache. And if you start a ACE inhibitor or ARB, they might complain of some postural dizziness. So the patient has been perfectly fine until you make the diagnosis of hypertension. And once you start the treatment, you have made the patient ill. So that is the main reason why this hypertension is difficult to control, because patients don't have the compliance with the treatment, because the treatment makes them sicker compared to the disease itself. Therefore, the best pressure pill is something that should be well tolerated with minimal adverse effects. Secondly, it should be affordable, right? And the third thing is, ideal pressure pill should have a long half-life. The reason is, say for instance, you use captopril to treat hypertension. So you give a tablet of captopril in the morning, and then it has a shorter half-life. So by 12 o'clock, 1 o'clock, patient will be having again high blood pressure. So you will need to dose the patient very frequently. And at the same time, what will happen is there will be a lot of blood pressure variability, which is not good for the patient, not good for the patient's organs. So if you go for a long-acting antihypertensive, that prevents the blood pressure variability, and at the same time, that will reduce the pill burden on the patient. So certain drugs like telmisartan, perindopril, amlodipine, they do have a fairly long half-life, right? And then finally, the most important thing is, whatever the pressure pill that you start should be preferred by the patient. Right. So then we discussed about the combination therapy. So from grade 2 hypertension onwards, we do combine antihypertensives from two different complementary classes. So these are the preferred combinations that we can try. So we can combine a thiazide diuretic and the ACE inhibitor or ARB. It's commonly available, losartan and HCT combinations. And then you can combine a thiazide diuretic with a calcium channel blocker. You can combine an ACE inhibitor or ARB with a calcium channel blocker. Or certain instances where there are compelling indications to use a beta blocker, we can combine a beta blocker with the non-hydropyridine calcium channel blocker. So this is important because sometimes we have seen that high doses of beta blockers are combined with non-dihydropyridine calcium channel blockers, such as diltiazem or verapamil. But combining a beta blocker with a verapamil or a diltiazem can be very dangerous because it can cause severe heart blocks and severe bradycardias. Another important thing is, this is again something that we see. Patient is on losartan 50 BD, and on top of that we have added enalapril 5 BD as well. So that is again very dangerous, can have significant renal effect and hyperkalemia. So ACE inhibitor and the ARB should never be combined in a combination therapy. Right. So having combinations, it gives the best smoothness of blood pressure control, and it sort of buffers the excessive blood pressure control over the 24-hour period. Right. So once you diagnose the hypertension, you start the treatment, you need to arrange a follow-up, because most of the patients will get defaulted in their follow-up. So what we can do is, we can recommend them to maintain a blood pressure diary where they regularly monitor their blood pressure. And that can be done maybe going to a local nearby hospital or to a nearby practice, or if the patient can afford, we can encourage them to buy a blood pressure meter. And always arrange follow-up lab investigations, right? So these patients are at risk of developing diabetes, dyslipidemia. So have interval measurements of their sugars and lipids. And at the same time, keep eye on their renal functions, because antihypertensives can have adverse effects on their kidneys. Sometimes your patient can become severely hyponatremic after you start in HCT, or else the patient can have acute kidney injury after you start a losartan. So always keep an eye on the kidneys when you're following up the patient. And whenever you follow up the patient, always reinforce the lifestyle changes, right? You can talk about the diet, you can talk about smoking, alcohol, and exercise, right? So this is the biggest problem we see, right? So we do everything, we start treatment, we diagnose hypertension, we start treatment, we advise them, but the blood pressure is always poorly controlled. So the commonest reason is, as we discussed earlier as well, poor compliance or non-adherence. So that is understandable from the patient's point of view because they had been perfectly fine, and after starting antihypertensive, they have so many complaints. So here, the health education is very important. That you always have to tell the patient that although this is asymptomatic, you might come with a stroke, you might come with a heart attack next week. So it's very important to control the blood pressure. The second biggest problem is with us, that is clinicians inertia, right? You always agree with me. So whenever we see patients with hypertension in the clinic, we check the blood pressure and it say 170, 100. The next immediate question we ask is, have you taken your morning antihypertensives? Then most of the time the patient will tell, no, I didn't take because I came early in the morning, I skipped my breakfast, so I couldn't take. And then what we do is we put an arrow and write in front of the blood pressure, not taken the morning antihypertensives, right? So we give them another 1 month to come back, right? And the other thing is sometimes the blood pressure is slightly high, not below 140/90, that is our target. And then you think, yeah, you must have rushed to the clinic. No, then the patient will also tell, yes, I took the bus and there was a lot of traffic and then I ran to the clinic. So then you attribute it to, okay, this is must be because patient has rushed into the clinic. So then we have a bit of we are not very aggressive in optimizing the blood pressure. We always let the blood pressure to be in the range 150 to 100. We don't want to sort of proactively work on that and optimize the treatment. We always follow what you call wait and watch policy, which is again another big reason why the blood pressure is poorly controlled. The third is co-administration of drugs causing hypertension. There are so many patients who take over-the-counter steroids, who take a lot of NSAIDs, and some patients on oral contraceptive pills. I mean, these too can contribute for the poor control of blood pressure. Then excess alcohol, substance abuse, again equally causing poor control. And excess salt intake. And white coat hypertension, obviously we discussed. And then there can be secondary causes, right? The patient has developed CKD. So with time, the blood pressure becomes increasingly difficult to control. And finally, you can have what you call a resistant hypertension. So resistant hypertension, to make a diagnosis, okay, the hypertension is resistant, you have to look into the other factors, right? So it's not just the definition, but if the patient is not compliant with the treatment, you can't make a diagnosis of resistant hypertension. If the patient is taking excess alcohol and lot of salt, etc., then you can't make a diagnosis of resistant hypertension, right? So always you have to look into the facts and see whether there's anything that can be treatable or reversible. And then finally you make a diagnosis of resistant hypertension. So the definition is appropriate lifestyle measures plus a thiazide diuretic and 2 other antihypertensives from different classes at adequate doses. Still the blood pressure is more than 140/90. You make a diagnosis, okay, this is resistant hypertension, right? Okay. And then what I thought was, rather than discussing more about how to evaluate a secondary hypertension, in the primary healthcare, what is the most important thing is to decide when to refer a patient to a specialist or to a tertiary care hospital. The reason being, most of the hypertensive patients are managed by the primary healthcare practitioners, right? And they do a wonderful job and the blood pressures are fairly under control. But there are certain instances where you should think, okay, this patient might need some further input with regard to its management or to the diagnosis. So the instances are, one is if you suspect a secondary cause, right? You diagnose the blood pressure and patient has neurofibromatosis. You see the neurofibromas all over the body. Okay, then you must think, okay, neurofibromas and hypertension, there must be secondary cause. Could be renal artery stenosis, or could be pheochromocytoma. Or else you see a lady who is looking very cushingoid with proximal muscle weakness, purple stripe. You have to think, okay, this could be secondary cause. So the best management managed by a specialist. So secondary cause is suspected, patient needs referral. The second thing is evidence of target organ damage. So patient has hypertension, but at the same time has a significant proteinuria. There is impaired renal function, or patient has heart failure or peripheral vascular disease. This patient needs referral to a hospital. And thirdly, young hypertensives. Particularly, say for instance, a 25-year-old boy comes to you and you read a blood pressure of 170/100, right? So this sort of a patient, it could be essential hypertension, I agree, but there can be secondary causes, and secondary causes are commoner among younger groups. So these people need referral to a tertiary center for further evaluation. And sometimes we might start treatment in the primary health care, but that will have sort of adverse effects on the patient's management and diagnosis. Sometimes we get young hypertensives who are already started on losartan. So it is very difficult to do certain blood tests, particularly if you are thinking about a cons to do a aldosterone-renin ratio. They should be off this medication for at least a couple of weeks. Therefore, in a young hypertensive, it is best if you could avoid the treatment and refer to a tertiary care center or a specialist. And then the resistant hypertension. So you have done everything, you have optimized all the medications, advised about lifestyle changes. Now the patient is on 3 antihypertensives, but still you always read a blood pressure of 150/100. That is the time you refer the patient to a tertiary care center. And also, if you suspect white coat hypertension or masked hypertension, if the ambulatory blood pressure can be arranged, that's fine. But in primary health care, it is not widely available. So in this sort of scenario also, patient needs a referral to a tertiary care center. And finally, patients with multiple drug intolerances. This is again a common thing that you will encounter. Initially, you start amlodipine or nifedipine, and patient refuses because he gets headache and leg edema. And then you consider starting HCT, then he might refuse, he has erectile dysfunction. Then you might consider starting an ACE inhibitor or ARB, but the next day patient comes, after the tablets, I feel dizzy. So there are a lot of drug intolerances. So in this sort of a patient also best managed in a specialist center, right? So always when you see the patients, if they fall into one of these categories, consider referring this patient to a hospital or for a specialist opinion, right? So, and okay, so this is, I think, the last slide where there are barriers. I agree. So there are barriers in managing hypertension primary healthcare setting, and the main barrier would be is within us. That's our clinical inertia or the lack of aggressiveness in initiating or optimizing the medications. And we need to have an updated knowledge on hypertension. And the other problem is there's lack of essential medications to blood pressure control. All right. So that brings to the end of the lecture. So basically what we have discussed was the burden of hypertension and the how to make a diagnosis of hypertension, and we had some special discussion about how to make a blood pressure measurement, and then the different classifications of blood pressure, and then the treatment categories like the lifestyle modifications and pharmacological treatment, and then the choice of medication, and then finally when to refer the patient to a tertiary care center or a specialist in the primary health care setting. Right. So that brings to the end of the lecture, and thank you for your kind listening.
Dr. Dalugama, thank you very much for your excellent talk regarding hypertension. So first of all, I start Q&A session. I need to tell all the audience for this month onward, we do the lecture sessions with collaboration with Sri Lankan College of Internal Medicine. I would like to thank Dr. Ganaka Serangan, President, Sri Lankan College of Internal Medicine, as well as Dr. Nandika Gnanasavan for coordinating on the side of Sri Lankan College of Internal Medicine. And before starting Q&A session, we have a request, Dr. Dalugama. They need to see the hypertension targets again. The slides.
Yes.
Right. The first question, what is the resistant hypertension and evaluation? You have discussed this topic. I think they need a bit of definition.
Yes. So basically, the resistant hypertension is where the thing is you have adapted all the lifestyle modifications. I'll just go to the slide as well. Okay. So you have adjusted all the lifestyle modifications, what we have discussed, and you have started the patient on a thiazide diuretic and two other antihypertensives. Say, for instance, patient is on losartan, patient is on nifedipine, and patient is on HCG, right? And we have increased the drugs to the optimum tolerable doses. And still, if your blood pressure is if you can't control the blood pressure to a value less than 140/90, that is labeled as resistant hypertension. But always to label it as resistant hypertension, you have to look into these factors as well, whether the patient is really compliant or not, and whether the patient is taking any other medications causing hypertension, excess alcohol, excess salt, etc. So you eliminate all these other confounding factors. Patient is very compliant, lifestyle measurements are appropriate, and he's taking these three medications, still the blood pressure is high, then that becomes resistant hypertension.
Second question is, what is the young hypertension definition? And instances we consider this patient has a young hypertension.
Sorry, the last part I didn't get. Reasons.
So what are the instances we consider when we encounter in the first place this patient has a young hypertension? Is it only the age?
Yes. Okay. So basically, the young hypertension, the age actually is a bit arbitrary because we don't have a clear cutoff value as such. But usually we consider if you diagnose a hypertension in a person who is younger than 35 years of age, that can be labeled as young hypertension. And most of the time, the young hypertensives also can have essential hypertension. If you see the patient, sometimes you might find a patient who is very obese and who has other metabolic risk factors where the blood pressure is also high. But there are certain instances where younger people, the hypertension is due to a secondary cause. So even in young hypertension, the commonest is essential hypertension. But if you take proportions wise, the younger people has a higher risk of having other secondary causes, maybe a renal artery stenosis, maybe some endocrine cause, etc. So then in that scenario, we'll have to sort of investigate for that, right? So if you have a 60-year-old man coming with hypertension, we don't do all sort of advanced investigations to looking for etiology. We attribute, okay, this is his age and must be essential hypertension. But in a 25-year-old, before attributing this for essential hypertension, we will see whether he has anything to do with his kidneys, whether he has evidence of coarctation of aorta, whether he has any endocrine problems. So to assess this, you need a good history, an examination, and some advanced investigations. And so this is sometimes difficult to arrange in the primary healthcare setting. So this sort of a patient might need referral for further investigations.
Right. The second question, third question regarding age specific cutoffs for the hypertension. I think the audience asking whether there is an age specific cutoff we consider in hypertension values.
Yes, of course, there have been different cutoffs, and the latest, most of this I have taken from the International Hypertension Society guidelines. So if you just read the guidelines, there are so many, and in 2020, there's the International Society of Hypertension guideline where they redefined the age cutoffs. So according to that, when we set targets, let me show you the slide. Yes. Targets, in all patients, we have to target the blood pressure less than 140/90. And I think this is the target, but you ask about the diagnosis, right? So diagnosis, that age cutoff has been taken off. Now, if the office blood pressure is more than 140/90, in repeated measurements, you make a diagnosis of hypertension irrespective of the age. Earlier, there was a room where for elderly people, we went up to 150/90, but now that has been removed.
Is there a difference of using blood pressure monitoring by digital meter or manual blood pressure monitoring meter?
Okay, I mean, that's a bit of a difficult question. There can be. The reason is, one thing is it depends on the calibration, and then it is the manual blood pressure meter is largely observer dependent. Right? There can be a lot of interpersonal variabilities, but if you follow the correct technique in a manual blood pressure meter, and if you use a well calibrated digital blood pressure meter with the appropriate cuff size, they should be more or less comparable.
Right. We discussed about hypertension. What are the signs we would consider a patient has a white coat hypertension?
Okay, so one thing is, usually this white coat hypertension is commonly seen in people who are a bit anxious, right? So usually, along with the blood pressure, they can be a bit tachycardic, and then sometimes they will show other. When you look at the patient, they may be a bit fidgety and they may be a bit anxious. And the other thing is that when you sort of look into the investigations and when you examine them clinically, they hardly have any hypertension-mediated organ damage. Right, so their creatinine is fine, the UFR is fine. Always they read high blood pressure, but they don't have evidence of hypertension-mediated organ damage. So in that instance, you will have to consider, could this be white coat hypertension, and then to offer them ambulatory blood pressure monitoring.
Next question is evaluation of secondary hypertension, examination and investigations briefly.
Yes. So again, secondary hypertension that can be due to many causes. So you will know there can be a lot of endocrine causes. It could be Cushing's. Okay, I'll get the slide that well. Yeah. So endocrine causes, it could be Cushing's, it could be acromegaly, it could be thyrotoxicosis, primary. I mean, there are endocrine causes, and there are vascular causes, and then there are other causes like obstructive sleep apnea, etc. So in the history, there are certain things that we can ask. Right, so if it is acromegaly, the patient obviously in history might tell, okay, I have noticed my arms, like my hands are getting bigger, my face is becoming a bit coarse, and I don't look like as I looked like 10 years back, something like that. And then if it is like Cushing's, they might have significant proximal muscle weakness. They might have a recent diagnosis of diabetes. They will complain that they are having easy bruising, etc. And hyperthyroidism, obviously, they will have thyrotoxic symptoms. Likewise, from the endocrine causes, from the history, there's a lot of things that we can sort of ask. And when it comes to examination, again, the general appearance of the patient, whether he looks acromegaly or Cushingioid or thyrotoxic. And then we can look for radiofemoral delays to look for coarctation. And then we can carefully auscultate for a renal bruit, which may suggest a renal artery stenosis. And we can feel for kidneys, ballot for kidneys, and you might feel ballatable kidneys if it's a polycystic kidney disease. So likewise, from the history and examination, there is a lot of things that we can gather and sort of narrow down, could this be this? And according to that, we can arrange further advanced biochemical testing to confirm our diagnosis. Say, for instance, you have a patient coming with muscle weakness and you find the patient is hypokalemic as well. So then few possibilities are, you might consider, could this be primary hyperaldosteronism, or could this be renal artery stenosis, and could this be Cushing's? So then you will arrange investigations accordingly. So you might arrange an ultrasound scan with renal artery Doppler to see whether the renal artery stenosis is there, or else you might arrange a renin-aldosterone ratio to see whether there is any differences between these ratios. Likewise, there are so many things that we can do as advanced investigations. So it's a compilation of history, examination, and investigations together to come to a diagnosis.
Right. What is the cutoff we need to admit a patient with a high BP without hypertensive-mediated organ damage?
Okay, so that is again a bit arbitrary, because the CCP guideline, they talk about the blood pressure say more than 220 by 110 without hypertension-mediated organ damage to consider immediate admission. So that, because sometimes there can be asymptomatic target organ damage where we cannot sort of diagnose at the clinic setting. So I can't give you exact figure as such, but if the blood pressure is say 180 by 110, where we talk about grade 3 hypertension, where we look for evidence of hypertensive emergency, you can consider admitting this patient to hospital. But obviously, if the patient has hypertensive mediated organ damage, definitely he needs immediate admission.
This is again a frequently asked question. What is the first line drug we use in a hypertensive patient with LLD? More than 55.
Okay,
Yes.
so yes, so from this 2020 International Society of Hypertension guideline, they prefer starting them on a calcium channel blocker. But if the patient has other things, say for instance diabetes or any evidence of what you call LBH or heart failure or any other cardiac condition, then an ACE inhibitor or ARB would be preferred. But if the patient is otherwise well, just hypertension and old person, then you can consider calcium channel blocker as the first line.
Right. We need to roll out some question on combination therapy. What are the combination therapy we can use calcium channel blocker within calcium channel blockers? Can we use them together? Two calcium channel blockers?
Yes, the problem is when it comes to the dihydropyridine calcium channel blockers, we have nifedipine and amlodipine, so they should not be used in combination. But certain instances where the nifedipine and verapamil, again, this is not recommended, but sometimes we can have some compelling indications to use. In that case, we can consider, but it is best to be avoided using different classes of calcium channel blockers to treat hypertension.
Next combination is angiotensin receptor blocker and ACE inhibitor. This has been misused very much. I think it's better to consider again discuss.
Yes. The problem is the ACE inhibitor and the ARB should never be combined together. So this is something that we commonly see patients on full dose losartan and they are started on enalapril because the blood pressure is not controlled. The problem with this is that this can cause life-threatening hyperkalemia and sometimes severe renal impairment. So always make sure that patient is not co-prescribed a ACE inhibitor and an angiotensin receptor blocker.
The next one is what is the indication for aspirin in a patient with hypertension?
Okay, so that is again a bit of a controversial area. So there are different guidelines recommending different things because from the few recent trials, they have discouraged using aspirin as primary prophylaxis. But usually what we do is in a hypertensive patient, obviously if they have coronary artery disease, for secondary prevention, the patient need to be on aspirin. But if it is not, what we can do is we can calculate the 10-year cardiovascular disease risk. So there are different calculators. So there is one thing called Atherosclerotic cardiovascular disease risk estimate calculator where you just have to put the patient's age, gender, and whether there is a diabetic, whether it's a dyslipidemic, and what's the systolic blood pressure, diastolic blood pressure. And then you can get a risk assessment where the cardiovascular disease risk, if it is more than 10%, that means within the 10 years, there is a 10% chance that this patient will get either a stroke or a heart attack. He will warrant aspirin as a primary prophylaxis. So this can be considered, but there's no standard guidance for this as such.
We encounter a lot of patients with the renal impairment and hypertension. So what are the drugs we can use with the renal impairment with high BP? And what is the creatinine value we consider when you starting and continuing the drugs? And in a patient with high BP and hyperkalemia, what are the drugs we can use?
Okay, so one thing is now renal impairment, there can be two things. So one thing is patient can have stable serum creatinine, stable CKD. So in a patient with a stable CKD where the creatinine is 200 and that has been there for several years or months. So in that case, if the patient has proteinuria, still you can consider an ACE inhibitor or ARB to have the anti-proteinuric effect as well. But if the patient is having an acute kidney injury, say for instance, the creatinine is rapidly rising, in that sort of a scenario, starting an ACE inhibitor or ARB would be counterproductive. So always, whenever you see a creatinine, you have to see what's the trend. Probably over the clinic visit, you can see what's happening to the creatinine, and if the patient has a stable CKD, you can consider. But if the creatinine is rapidly rising, if you suspect an element of acute kidney injury, you should avoid ACE inhibitors and ARBs. In this category, you can safely consider starting them on a calcium channel blocker. But the problem with thiazide diuretic is when the GFR is low, the thiazide diuretics are not going to be effective. So in patients with say CKD stage 3 and above, the thiazide diuretics should not be used. And then when it comes to hyperkalemia, best to avoid ACE inhibitors and ARBs, but you can consider starting them on calcium channel blockers. And then if you need further antihypertensives, you can consider other second-line treatments that is available. So we have prazosin, which is a drug that we can use, particularly in renal patients, in whom we can start ACE inhibitors and ARBs, and the blood pressure is controlled, but blood pressure control is poor with a calcium channel blocker.
Next question came from actually for a MOH level and community level. What are the preventive measures to control hypertension in a community level? Can we use any measures as a primary prevention?
Yes, obviously. So what the non-pharmacological measures that we have discussed. So one thing is, it's mainly the patient education that we have to sort of target, and then optimizing the lifestyle. So one thing is the diet that I have discussed, the DASH diet, which is not so difficult. So there can be health education programs sort of improving this sort of dietary practices, and then encouragement of exercise. So basically the recommendation is that if you take aerobic exercises, at least 30 minutes a day, 5 days a week, right? So those aerobic exercises should be defined according to the community. Sometimes, I mean, the basic definition would be any activity that will increase the heart rate and the respiratory rate. So even gardening, even farming can be taken as a form of exercise, aerobic exercise. So this exercise needs to be sort of improved and implemented, and then discouraging or advice on quitting smoking and cutting down on alcohol, and these basic lifestyle measures can be implemented even in a group of non-hypertensive patients as a primary prophylaxis measure. And the other thing is that the primary health care, the most important thing would be to go to the community and try to diagnose hypertension in the community, because from the figures, 1/3 of Sri Lankan adults are hypertensive, but the number that we treat is much lesser than that, because patients have never had a blood pressure reading in their life. So if you take the community approach to check the blood pressure and the diagnosed hypertension, and then according to the blood pressure offer either the lifestyle changes or to start them on treatment, that would be very beneficial.
Exactly. In considering ACE inhibitor and ARB, which one is the best? In a lot of prescription we see ARB is prescribed over the ACE inhibitor without much indication. What is your opinion?
Yes, so the problem is here the ACE inhibitors and ARBs, the efficacy wise more or less the same, but certain trials they have used ACE inhibitors over ARBs. So when you go through the evidence-based medicine, the drugs that they have mostly used for these clinical trials are ACE inhibitors. But the other problem is the patient side effect profile. Some patients do tolerate ARBs much better than ACE inhibitors, because with ACE inhibitors they tend to get cough and particularly the dry cough, which they don't tolerate. So therefore, personally, I would think ACE inhibitors and ARBs, the choice should depend on the patient's preference and the patient's how the patient respond to them.
Next question is, what are the diuretics we can use in hypertension management?
Yes, so
diuretics we can use in hypertension management.
Yes, okay. So to have a hypertensive effect alone, I mean, the thiazide diuretics is the type of diuretic that we use. But sometimes in patients with heart failure, the furosemide be used for the symptomatic benefit, which can have antihypertensive effect. And when it comes to spironolactone, the other diuretic, which is the potassium-sparing diuretic, it is used to treat hypertension particularly, as a fourth line treatment, or else in special instances where their secondary cause is due to primary or secondary hyperaldosteronism. So hyperaldosteronism causing hypertension, the spironolactone is the drug of choice. But in other conditions where in resistant hypertension, as a fourth line we can use spironolactone, but not otherwise as a first line treatment.
Same question. Can we use furosemide, loop diuretics, as sole hypertensive management drug patient without edema or fluid overload?
No, I think that should be discouraged because furosemide is not, I mean, it's good for heart failure, but it has so many other side effects. You must have seen that a lot of patients come in with cramps, severe hyponatremia, and a lot of other side effects. So furosemide alone should never be used as the first line antihypertensive if there's no edema or features of heart failure. But it has a hypertensive effect where you use that when you treat appropriately in a heart failure setting, but not otherwise.
Right. In calcium channel blockers and ankle edema. So, frequently encounter problem. What are the early prediction factors and what are the alternative drugs available for us?
Okay, so one thing is this ankle edema due to calcium channel blockers can be a sort of class specific. So you use nifedipine, and some patients might get ankle edema with nifedipine, some might not, and some might get it with amlodipine or other calcium channel blockers. Right? So you have to always discuss with the patient and to see how troublesome it is, and then sometimes you can sort of go for a switch inside the calcium channel blockers, either nifedipine to amlodipine, but still if the ankle edema is there and if that is worrying the patient, then you have to sort of, because the patient's preference is very important when it comes to compliance. So if the patient doesn't prefer to take it because the ankle edema is significantly affecting him or her, then we have to go for other alternatives. We have to select either ACE inhibitor or ARB or a thiazide diuretic or the calcium channel blocker.
After diagnosing hypertension and follow-up, how frequent we should monitor the blood pressure, how frequent we need to do other rest of the investigation throughout the follow-up.
Okay, so that of course should be tailor-made according to the patient. So if the patient is having very high blood pressure and you start treatment, so the initial period you might need to see him more frequently. And in the initial workup, if there is, say for instance, there is some degree of renal impairment, there's a bit of a hyperkalemia, etc. In that sort of setting, patient will need more frequent monitoring of the blood investigations. So it's always, you need to decide according to the patient. So if it is mild hypertension, you start a treatment and the patient is reliable, he has home blood pressure monitoring at home. So in that sort of a scenario, you can sort of, you don't have to see him so frequently. You may see him in a month, and then if the blood pressure is under control, even 3 to 6 months interval, you can see him, provided that he's monitoring the blood pressure and he's aware about the condition. And then if you start ACE inhibitor or ARB or a thiazide diuretic, the initial period, maybe within first 1 month or so, you might need to do the kidney functions and the electrolytes to look for complications. But if they tolerate it very well, then you will need, you don't have to do it very frequently, but you always have to advise the patient, particularly on thiazide diuretic, if they feel unwell, if they feel nausea, vomiting, if the family finds the patient a bit drowsy, to consider bringing to hospital and to get an electrolyte checked. That sort of advice need to be given, but the interval that you see this patient should always according to the patient's individual profile.
Right. This is the last question we have. In place of hypertension management, what is the place Presvin has, and why the beta blockers not in the first place?
Okay, because that is mainly because of the evidence. Now, beta blockers are good anti-angiogenic, but they have a modest antihypertensive effect. And then considering other antihypertensives, particularly when it takes ACE inhibitors and ARBs, they have other pleomorphic other effects, right? So they have effects on the myocardial remodeling, they have effect on the proteinuria, etc., etc. But beta blockers, other than anti-angiogenic effects, they don't offer that much of sort of prognostic benefit when it comes to the hypertension treatment. And particularly if the hypertensive patient has peripheral vascular diseases and all, beta blockers might worsen the symptoms. Therefore, beta blockers were initially the practice. It was A, B, C, or D that you have to decide. But over the last few years, because of this having better drugs to control hypertension, beta blockers were removed as a first-line antihypertensive agent.
The prazosin?
Yes, yeah, prazosin, of course. Prazosin has a lot of problems because prazosin can cause first-dose hypertension, and therefore prazosin is not recommended as a first-line treatment. So usually you try the first-line treatments, and then if the blood pressure is difficult to control, you can start prazosin, but as a third-line or a fourth-line drug.
Right. That will be all today Q&A session. I would like to thank again Dr. Chamara Dalugama connecting us all over from Peradeniya. As well as I would like to thank Sri Lankan College of Internal Medicine to mediate this process today and future events. So I would like to hand over the session to Dr. Romali to conclude our session. For the audience, if you have any questions furthermore regarding this topic, please let us know. You have our mail. Just send us. We'll send to our resource person accordingly, and answer will be given by as a mail. Thank you.
Okay, thank you very much, Iman.
Thank you all of you for joining us today this Sunday. We hope to see all of you next Sunday with another interesting topic in our webinar series. Hope you have a great day.